Abnormalities of cardiac rhythm, arrhythmias, may compromise cardiac output or induce cardiac ischemia. Appropriate treatment of an arrhythmia depends on accurate diagnosis of the type of rhythm disturbance present. Before we go on to discuss arrhythmia diagnosis, we need to briefly revise some relevant principles from cardiac physiology. We will focus in on the SA node at the cellular level to illustrate these principles. As demonstrated by the cell center field, all cells of the cardiac conducting system and myocardium maintain a gradient of electrical charge across their membranes, with the extracellular fluid demonstrating a positive charge relative to the intracellular compartment. This polarization of the cell membrane is an energy-dependent process. However, as shown here, virtually all electrically active cells in the heart have the capacity to spontaneously and rhythmically open ion channels in the cell membrane, with consequent equalization of charge. This capacity to periodically depolarize their membrane in the absence of an external stimulus is termed automaticity. As the membrane spontaneously depolarizes, a threshold is reached and an action potential is generated, which propagates out to surrounding cells, ultimately triggering depolarization of their membranes. In this way, once one region depolarizes, a wave of depolarization spreading through the entire organ is generated. Within the myocardium, depolarization spreads from cell to cell at a rate of approximately 0.5 meters per second. However, within the components of the ventricular conducting system, the velocity of conduction of depolarization is more rapid, between 4 and 8 times higher than that of muscle. This difference in conduction velocities between myocardium and the specialized ventricular conducting system is central to understanding the ECG analysis of arrhythmias. Cellular depolarization in conducting tissue and myocytes is followed by a slower phase of repolarization, and during much of the latter process the cell is refractory to further stimuli. During this refractory period, the cell will not depolarize either spontaneously or in response to an external stimulus. Cellular automaticity and the existence of the refractory period are crucial to understanding cardiac arrhythmias. The cells of the SA node have the highest rate of periodic depolarization, and therefore under normal circumstances the SA node drives the heart rate. However, if the SA node is damaged, other foci within the conducting system or myocardium can take over pacemaker function and drive cardiac depolarization. As one moves further down the conducting system away from the SA node, the automaticity of these latent pacemakers decline, and the heart rate generated by them will tend to be lower. When studying the videos in this section, it is very important that you are clear about one thing. In this section, section 4, we will only deal with the ECG diagnosis of arrhythmias in the presence of an intact ventricular conducting system. The diagnosis of arrhythmias in the presence of altered cardiac conduction is more challenging and must wait until section 5. Even in a normal heart, the inherent automaticity of cardiac cells occasionally results in tissue outside the SA node discharging and depolarizing the organ. This is the mechanism generating ectopic beats, a phenomenon experienced by almost every person at some point. In the vast majority of cases, this is of no clinical significance whatsoever. However, as you will see, in some individuals, ectopics play a key role in triggering life-threatening arrhythmias. Also, principles learned from the analysis of ectopics can be applied to help with arrhythmia diagnosis. This is a normal heart, and it is in sinus rhythm. At this point, a region of the atrium has developed enhanced automaticity and has discharged a depolarizing current. Initially, it triggers atrial depolarization. The wave is transmitted by the AV node into the ventricular conducting system, triggering ventricular depolarization. This is a premature atrial ectopic, or as it is frequently referred to, a premature atrial contraction. On the ECG, the premature atrial contraction occurs earlier than the next predicted sinus beat. Also, and very importantly, you will appreciate that as the ectopic discharge originates in the atrium, it must be transmitted into the ventricles by the AV node, and consequently into the ventricular conducting system. Therefore, as the wave is transmitted at normal speed around the chambers by the conducting system, the QRS complex associated with an atrial ectopic is of normal duration. That is, less than 3 small squares in width. In fact, the depolarization wave from a focus situated anywhere above the physiological bifurcation of the bundle of His will enter both branches of the intraventricular conducting system. Consequently, the QRS complex associated with discharge from a focus situated anywhere in this region will be of normal duration. Now here's a different situation. In this case, the site of increased automaticity generating the ectopic beat is located in the ventricle. The key point to note here is that the current is transmitted, at least in part, outside the ventricular conducting system. Depolarization moves through myocardium 4 to 8 times more slowly than through conducting tissue. So the characteristic of a ventricular ectopic is that the QRS complex is prolonged in duration, resulting in a broad QRS complex greater than 3 small squares on the ECG readout. Note also that the pattern of spread of depolarization is highly abnormal, producing a complex of bizarre shape. As the sequence of depolarization is deranged, the pattern of repolarization is also abnormal, manifesting as a lack of concordance between the ectopic QRS complex and the associated T wave. Looking at both of these rhythm strips, you will notice that the atrial and ventricular ectopic are followed by a pause before the next sinus discharge. There are, however, important differences between the nature of this pause in the case of atrial and ventricular ectopics. Understanding these differences will help us when dealing with more complex situations in Section 5. In the case of ventricular ectopics, while retrograde transmission of depolarization into the atria via the AV node can occur on occasion, it is an unusual event. A ventricular ectopic, therefore, is not usually associated with retrograde depolarization of the structures of the atria, including the SA node. The SA node continues to discharge at its own inherent rate, oblivious to events below the AV node. As the sinus node continues to discharge at its own regular rate, the next P wave following the ectopic will occur at a predictable time point. In addition, the heart rate following the ventricular ectopic is the same as that preceding it. A pause with these characteristics following an ectopic is termed a compensatory pause. A compensatory pause indicates that the ectopic has had no effect on the SA node, In the example shown here, the morphology of the premature ectopic is consistent with an origin in the ventricles. We would predict that it will have had no effect on the sinus node. Before the ectopic, there were approximately 4 large squares between P waves. We would therefore expect the next sinus discharge to occur at this point. Indeed it did. However, note that it was not transmitted into the ventricles, as it arrived at the junctional region at a time when the conducting system was still refractory to transmission. Also, in this particular example, as the sinus discharge occurred during ventricular repolarization, it is buried within the T wave associated with the ectopic and is not visible on the ECG readout. We would still predict that the next sinus discharge would occur at this point, a further 4 squares on. This is indeed the case. So the P wave following the ectopic occurs at a predictable point on the readout, which is a simple multiple of the preceding P wave interval. Also note that with 4 squares between all subsequent OR waves, the heart rate is the same as that preceding the ectopic. As expected, this is a compensatory pause and supports the conclusion that this ectopic originated in the ventricles. In contrast to ventricular ectopics, discharge from an atrial ectopic will usually result in depolarization of the cells of the SA node, temporarily suppressing their discharge. The SA node recovers its function after a pause of variable duration. As the duration of recovery is variable, the timing of the next P wave is not predictable. The next sinus discharge does not occur at a simple multiple of the P to P wave interval preceding the ectopic. Premature depolarization of the SA node also has a broader effect on its function and may reset its inherent rate of spontaneous depolarization, leading to a different heart rate, either faster or slower, following the ectopic. A pause with these characteristics is termed a non-compensatory pause. Before we summarize the material contained in this video, there are a number of other features of the atrial ectopic worth noting at this point. Firstly, in this particular example, the ectopic discharge has originated low in the atrial cavity, and the bulk of atrial depolarization is spreading upwards. The ectopic P wave is therefore negative in the inferior leads, illustrated here in the rhythm strip, lead 2, reflecting an abnormal P wave axis. You may also have noticed that compared to the normal sinus beat, the PR interval is shortened in the ectopic. This reflects the fact that in this particular case, atrial depolarization has arisen from a focus closer to the AV node than the sinoatrial node. The time taken to reach the AV node is therefore reduced, and the PR interval associated with the ectopic is shortened accordingly. You will see shortly that precisely this type of analysis can help us determine the site of origin of arrhythmias. So, premature ectopic beats can originate from sites of enhanced automaticity in the atria or ventricles. Both occur early, that is, before the next expected sinus beat. Atrial ectopics are transmitted into both branches of the ventricular conducting system and therefore are associated with a normal QRS complex. Atrial ectopics are usually associated with a non-compensatory pause. In contrast, ventricular ectopics are generated in the ventricular wall or a component of the conducting system, and must travel at least in part through the slower conducting ventricular muscle. Consequently, they are associated with broad QRS complexes and deranged repolarization results in a non-concordant T wave. In addition, ventricular ectopics are usually followed by a compensatory pause. Looking at this rhythm strip, we note the presence of a premature atrial contraction, and at first glance there does not appear to be any P-wave deflection associated with the ectopic event. However, if you look closely, you will see that the morphology of the T-wave associated with the preceding sinus beat is altered compared to those around it. We can explain this and introduce an important concept by watching events in the heart around the time of the ectopic. Starting with the preceding normal sinus beat, if we freeze events at this point, you can see that discharge from the ectopic focus has occurred during the late phase of ventricular repolarization associated with the preceding sinus discharge. Consequently, the ectopic P wave has been recorded as a small second peak on the preceding T wave. This is an example of fusion. Two electrical events in the heart have occurred at the same time and are recorded by the ECG machine. Their composite effect on the readout produces a fusion complex, which differs in morphology from the surrounding normal complexes. The effect can be much more subtle than shown here. In this example, the ectopic P wave is not visible as a second peak, but is merely added to the height of the preceding T wave deflection, producing a T wave which is taller than normal. Searching for evidence of hidden P waves in this way will become a very important skill when analysing arrhythmias. Note that the fusion of the waves observed in the example used here is purely an electrocardiographic phenomenon. In the heart itself, the waves do not meet, as they are separated by the atrioventricular septum. They fuse on the ECG readout simply because they occur at the same time. In some cases, a fusion complex may result from an actual physical fusion of the relevant electrical waves in the heart. In the situation shown here, a sinus discharge is generating QRS complexes of normal morphology. A ventricular ectopic focus has fired at this point, generating a QRS complex of the expected bizarre wide morphology. Sometime later, the ectopic focus has fired again, but on this occasion, just as a sinus discharge is traversing the AV node. The ventricles are partially depolarized by the sinus discharge and partially by the ectopic wave. Eventually, the two ventricular depolarization waves meet and cancel each other out. The QRS fusion complex generated will demonstrate features of both contributing QRS complexes. Identification of this type of fusion beat will be a crucial skill when we go on to analyze tachyarrhythmias. Tachycardia is defined as a heart rate of 100 beats or more per minute. When faced with a tachycardia on the ECG, identification of the anatomical location and nature of the focus of depolarizing current generating the arrhythmia has a critical bearing on treatment. Initially, we will concentrate on the identification of the anatomical location of the abnormal depolarizing focus. An understanding of the mechanism generating different tachycardias will come with analysis of the individual types. Tachyarrhythmias may be divided into two major groups, depending on whether their focus of origin is situated above or below the bifurcation of the bundle of His. A tachycardia arising from an abnormal focus in the ventricular muscle mass or in the conducting system below the bifurcation of the bundle of His is termed a ventricular tachycardia. For the reasons outlined in the video on ectopic beats, tachyarrhythmias arising from a focus in this region are associated with broad QRS complexes. Tachycardia arising from a focus in or anywhere above the bundle of His is called a supraventricular tachycardia. In this case, as the depolarization wave generated must enter the ventricles via the AV node and therefore the ventricular conducting system, a tachyarrhythmia arising from anywhere in this region is usually associated with QRS complexes of normal duration, a so-called narrow complex tachycardia. There are exceptions to this simple division, however. For example, it is possible for a focus in the supraventricular region to generate a broad complex tachycardia when conduction between the atria and ventricles, or within the ventricles themselves, is abnormal. Distinguishing this possibility from ventricular tachycardia is an important skill, but this must wait until section 5. We will deal with tachycardias arising in the supraventricular region first. Supraventricular tachycardias may arise from the sinoatrial node or an ectopic focus in the main mass of the atria. In addition, the area encompassing the AV node, bundle of His, and immediately surrounding atrial tissue is a highly arrhythmogenic area of the heart. This area is referred to as the junctional region, and arrhythmias arising from a focus within this region are termed junctional. We will now show you how to distinguish between narrow complex tachycardias arising from each of these three supraventricular zones. This ECG is taken from a previously healthy 23-year-old lady who presents with a pyrexia of 40 degrees Celsius secondary to pyelonephritis. The heart rhythm is regular and there are 12 small squares between R waves, so the heart rate is 125 beats per minute, a tachycardia. The QRS complexes are of normal duration, less than 3 small squares in width, indicating that the depolarization wave is entering the ventricular conducting system. Therefore, we can conclude that the tachycardia has originated from a focus located above the bifurcation of the bundle of His. We note that P waves are present, and we can identify the site of origin of the tachycardia within the supraventricular region by analysis of the P wave axis and PR interval. In fact, the P wave axis is normal. We find upright P waves in both the inferior leads 2, 3 and AVF, and the left-sided leads 1 and V5 and V6. This indicates that the bulk of atrial depolarization is proceeding downwards and to the left. Also, the PR interval is within the normal range. This is at least consistent with a normal distance travelled by the atrial depolarization wave from its origin to the AV node, and preservation of physiological delay within the node. Based on this analysis, we can be reasonably confident that this is a sinus tachycardia, a tachycardia originating in a rapidly discharging SA node. Furthermore, the patient from whom this ECG was taken had a pyrexia of 40 degrees Celsius, so sinus tachycardia would be expected in the clinical context. Although a very simple case, our approach to this ECG highlights some of the principles we will use in the analysis of tachyarrhythmias. We used the width of the QRS complex to determine if the tachycardia is supraventricular or ventricular in origin. As it is a narrow complex tachycardia, we concluded that it originates from a focus above the bifurcation of the bundle of His. We then used the presence, axis and timing of the P wave relative to the QRS complex to determine the most likely site of the depolarizing focus within the supraventricular region, in this case the SA node. The clinical context is also important in reassuring us that our ECG diagnosis is correct, as sinus tachycardia would be expected in this scenario. When a supraventricular tachycardia arises from a focus within the junctional region, depolarization will proceed upwards into the atria, and ventricular activation will travel as normal downwards into the conducting system. As atrial depolarization spreads superiorly, the P waves in the inferior leads are negative. In addition, this altered P wave axis is accompanied by an abnormally short PR interval, as the discharge has little, if any, distance to traverse before reaching the AV node, and may actually bypass the normal physiological delay within the node. In fact, depending on the site of origin of the discharge within the junctional region, in some cases of junctional tachycardia, atrial depolarization may be coincident with ventricular depolarization. In such cases, the P wave is not visible as a separate entity on the ECG readout, being buried in the QRS complex. In this scenario, we see a regular, narrow complex tachycardia with no obvious P wave activity. It is even possible for atrial depolarization to follow ventricular depolarization in a junctional rhythm, with the P wave occurring after the QRS complex. So, a tachycardia arising from a focus in the junctional region is regular, narrow complex, and is characterized by a shift in the P wave axis such that the P waves are negative in the inferior leads. The PR interval is shortened. The degree of shortening varies to the extent that the P wave may precede the QRS complex, but with a PR interval less than the lower limit of normal. Alternatively, the P waves may be coincident with the QRS complexes and consequently unidentifiable on the ECG readout. In some cases, the P wave may follow the QRS complexes. Looking at this ECG, we identify a narrow complex tachycardia with a rate of 115 beats per minute. Negative P waves in the inferior leads indicate that the P wave axis is travelling superiorly, away from these leads. This, combined with an abnormally short PR interval, places the source of the depolarizing discharge in the junctional region. This is a junctional tachycardia. Tachycardia arising from a discrete focus in the main mass of the atria, outside the sinus node and junctional region, is termed ectopic atrial tachycardia. The patient from whom this ECG was taken has clearly developed a narrow complex tachycardia. If we focused on the rhythm strip alone, with upright P waves and a normal PR interval, we might reasonably suspect a sinus origin for the tachycardia, but this would be incorrect. Looking at the full 12-lead ECG, we note that the P waves are indeed positive in the inferior leads, indicating that the bulk of atrial depolarization is moving downwards from its origin. However, on closer inspection, we note that the P waves are negative in lead 1 and V5 and V6. This indicates that atrial depolarization is predominantly moving from left to right, and therefore does not originate in the sinoatrial node. This is in fact an ectopic atrial tachycardia, originating from the focus indicated. Analysis of this ECG illustrates a number of principles. Firstly, in general, if P waves are negative in any of leads 1, 2 or 3, or V5 and V6, the origin of atrial depolarization is ectopic, that is, it lies outside the sinus node. Secondly, as a general point, if the patient clinical condition allows it, a full 12-lead ECG should always be obtained when trying to diagnose an arrhythmia. We will discuss ectopic atrial tachycardia again in the quiz section. For now, this slide summarizes the main features of tachyarrhythmias arising from a focus in each of the 3 supraventricular zones. We will now consider 2 closely related arrhythmias with well-defined underlying pathogenic mechanisms arising in the supraventricular region. Atrial fibrillation is a very common and clinically important arrhythmia. The most striking finding on the ECG in this disorder is that the heart rhythm is irregularly irregular, the distance between aura waves varying from beat to beat with no discernible pattern. If we mark out a set of aura waves on a piece of paper, moving along the rhythm strip, we find no fixed relationship between episodes of ventricular depolarization. Furthermore, there are no identifiable P waves. These are the characteristic ECG findings in atrial fibrillation. Atrial fibrillation arises secondary to many different disease states, both intrinsic and extrinsic to the heart. In this arrhythmia, multiple sites within the atria, in the example shown here 8 but often many hundreds, are depolarizing randomly and independently of one another. However, the individual depolarization events generated by these sites never manage to completely depolarize the atria, as they run into refractory zones generated by earlier discharges from other sites. These relatively small depolarization events are therefore referred to as wavelets. Atrial wavelets produce deflections of variable morphology, and these deflections, occurring at a rate between 400 and 700 per minute, are termed F waves. If we remove the QRS complexes and T waves, we can see that F wave activity results in a continuous, chaotic disturbance of the isoelectric line. As P waves are generated by the coordinated spread of depolarization over the atria in a defined period of time from a discrete depolarizing focus, in the presence of atrial fibrillation, P waves are absent. Even if a depolarization wavelet reaches the AV node, It may or may not be transmitted into the ventricles depending on whether the node is permissive or refractory to transmission. Within the AV node, the depolarization wavelet may be blocked in its journey to the ventricles by intranodal refractory foci generated by previous wavelets. As these refractory regions complete repolarization, a depolarization event arriving at the same point at a slightly different time, however, may manage to negotiate its way through the node and discharge into the ventricular conducting system, triggering ventricular depolarization. The net result of these chaotic supraventricular events is a random generation of narrow QRS complexes with no evidence of P-wave activity on the ECG. These are the characteristic ECG features of atrial fibrillation. In this example, with 12 OR waves in 30 large squares, the heart rate is 120 beats per minute. Rates between 120 and 140 beats per minute are typical. However, the actual heart rate observed in cases of atrial fibrillation is highly variable. It may be much more rapid than shown here, however, it may occur at a rate within the normal range, or even be slow enough to qualify as a bradycardia. When the heart rate associated with atrial fibrillation is less than 100 beats per minute, it is described as controlled atrial fibrillation. In the absence of treatment, controlled atrial fibrillation is often observed in elderly patients. This is because in this age group, atrial fibrillation is frequently associated with significant underlying heart disease. In this situation, the AV node may be diseased and transmission of atrial depolarization wavelets to the ventricles impaired. As in this example, F waves may be quite prominent. In many cases, as shown here however, they are of low amplitude with minimal disturbance of the isoelectric line. These two situations are sometimes referred to as coarse and fine atrial fibrillation. Coarse atrial fibrillation probably arises when the number of depolarizing sites in the atria is limited to less than 10, and each individual electrical event affects a mass of atrial muscle significant enough to cause a substantial wave on the ECG readout. Fusion of such coarse underlying F waves with T waves and QRS complexes may distort their appearance. Fine atrial fibrillation occurs when the number of atrial sites depolarizing is larger, the multitude of smaller individual wavelets resulting in less net disturbance of the isoelectric line. In reality, a full spectrum between coarse and fine atrial fibrillation is observed in patients, and the distinction has no clinical significance at the present time. Atrial fibrillation is associated with a number of preventable complications, including stroke and heart failure. You must be able to identify it on the ECG. The key to identifying this arrhythmia is the irregularity of ventricular depolarization and the absence of P waves. We will now study a related arrhythmia generated in the supraventricular region. Atrial flutter arises by a very specific mechanism. In this arrhythmia, a loop of depolarizing activity circulates constantly within the walls of a diseased right atrium, discharging depolarizing current into the left atrium. This is a re-entrant loop and is our first encounter with the phenomenon of re-entry. We will explain exactly what this means in the next videos. However, we need to discuss atrial flutter here as it is closely related in terms of etiology to atrial fibrillation. In fact, it is very common to see patients who flip between these two arrhythmias. In flutter, the rapidly discharging loop of current in the walls of the right atrium rotates anti-clockwise, discharging into the left atrium at approximately 300 discharges per minute. If we mask ventricular electrical activity for the moment, you will see that the discharge of depolarizing current from the reentrant loop produces a large negative deflection in the inferior leads, illustrated here in lead 2. These are flutter waves. At a rate of 300 discharges per minute, the flutter waves are of course present at intervals of approximately 1 per large square. This is the sawtooth pattern characteristic of atrial flutter. Identification of elements of this underlying pattern is the key to the diagnosis of this arrhythmia, but it is not always easy. Remember, we are looking here at a particularly striking example and with ventricular activity removed. So what effect does this process have on the ventricles? The atria are depolarizing approximately 300 times every minute. If this were transmitted to the ventricles, a ventricular rate of 300 beats per minute would be potentially fatal, as the chambers fail to fill between beats. The AV node protects the ventricles and cardiac output by selectively blocking transmission of a proportion of flutter waves. In the example shown here, the AV node is conducting 1 in every 4 flutter waves, giving a ventricular rate of 75 beats per minute. Note how easy it is to make the diagnosis in this case. With this low level of conduction, we can easily identify the flutter waves between episodes of ventricular activity. This is atrial flutter with 4:1 conduction. Real problems in diagnosing this arrhythmia arise when higher rates of AV conduction are present. A healthy AV node will typically conduct every second flutter wave, resulting in a regular narrow complex tachycardia of 150 beats per minute. You will appreciate that identification of flutter waves in this situation is much more difficult, as the electrical events of ventricular depolarization and repolarization fuse with every second wave, obscuring it and also distorting its shape. The diagnosis may be particularly difficult when, as is often the case, the flutter waves are of low amplitude. Yet even here the pattern can be identified by the practiced eye. This is atrial flutter with 2:1 conduction. This ECG emphasizes the importance of a high index of suspicion in the diagnosis of atrial flutter. The ECG is taken from a patient with a long history of poorly controlled hypertension, who presented with marked hypoxia secondary to bronchopneumonia. We note that his heart is structurally abnormal, with clear evidence of left ventricular hypertrophy on the ECG. We are aware that hypoxia is a potent trigger of arrhythmias in the presence of heart disease. We also note that the tachycardia is monotonously regular, with a heart rate of 150 beats per minute. This should immediately alert us to the possibility of underlying atrial flutter. Although no obvious flutter waves are present, examining lead V1, however, we note a deflection consistent with P-wave activity preceding the QRS complexes. A repeat ECG with V1 as the rhythm strip shows the deflection to be a consistent feature. These putative P-waves are present at intervals of 10 small squares, that is, at a rate of 150 per minute. So could this be a sinus tachycardia arising in response to hypoxia? It could be. However, closer analysis of the readout at a point exactly halfway between P waves shows this consistent distortion of the QRS complex. It is of the correct orientation and represents P wave activity fused with the terminal portion of the QRS complex. So atrial depolarization is occurring at a rate of once every large square, that is 300 times per minute. This is atrial flutter with 2:1 conduction. Analysis of this ECG shows how easily one can miss this diagnosis. As a general principle, when faced with a regular tachycardia demonstrating a rate of or close to 150 beats per minute, always examine the ECG closely for flutter waves or any evidence of atrial depolarization occurring at a rate in the region of 200 to 400 times per minute. This ECG also emphasizes the fact that lead 2 is not always the best place to analyze atrial depolarization, highlighting again the value of a full 12 lead ECG in the diagnosis of arrhythmias. Before we go on to explain the mechanism of AV nodal reentrant tachycardia, we need to look at the structure of the junctional region in a little more detail. Atrial depolarization is conducted into the AV node by a specialized tract of conducting tissue. In 90% of individuals, this tract is singular. 10% of subjects, however, are born with two tracts leading into the node. And crucially, these tracts have differing electrical properties. One depolarizes and repolarizes at a normal rate, while the other transmits depolarizing current abnormally slowly, but repolarizes abnormally rapidly. A situation such as this, where two conducting tissues with differing electrical properties are in communication within the heart, is the basis of all reentrant arrhythmias. This situation is an accident waiting to happen. To explain why, we will focus in on events in the region of the AV node during the cardiac cycle. This close-up of the junctional region shows the two tracts leading into the AV node through the surrounding non-conducting tissue, shown here in black. The diagram also shows the proximal portion of the bundle of His and a small portion of the atrioventricular septum. Depolarization will approach the node from the atrial myocardium above. During the normal cardiac cycle, the SA node discharges and the depolarizing current generated travels through the atria to reach the region of the AV node. We will now slow down events at the node to aid comprehension. Depolarizing current enters both the normal and abnormal tract. The depolarization wave is transmitted through the normal conducting tract at an appropriate rate and depolarizes the node. Atrial depolarizing current has also entered the abnormal tract and begins its relatively slow journey through this tissue. However, at this point, current flowing in the normal conducting tissue has already reached the distal end of the abnormal strand and is conducted in a retrograde direction into this tissue. The two currents in the abnormal strand meet at some point and obliterate one another. The small, short-lived currents in this tiny strand of abnormal tissue are not detected by the ECG machine, so absolutely no abnormality is detected on such an individual's resting ECG in sinus rhythm. Following these events, the normal tract goes through a normal period of repolarization, while the abnormal tract repolarizes rapidly. With the heart in normal sinus rhythm, this process is repeated with every sinus discharge, and the existence of the abnormal tract has no consequences whatsoever for the subject. However, if the individual experiences a premature atrial ectopic and atrial depolarization reaches the tracts at this point, the effect can be dramatic. The ectopic discharge has arrived at a time when the normal conducting tissue of the node is in a state refractory to the transmission of current. The abnormally rapidly repolarizing tissue of the diseased section, however, permits current to pass. Now, the slow passage of current through the abnormal section allows enough time for the normal tract to repolarize, and current arriving at the distal end of the abnormal tract is propagated not only into the AV node and into the ventricles, but also in a retrograde direction by the normal conducting strand. By the time the current reaches the proximal end of the normal tract, the rapidly repolarizing diseased section is ready to conduct again. In this way, a cycle of circulating current is established. In the small area of the junctional region, the combination of an unfortunately timed atrial ectopic and the existence of conducting tissues with opposite electrical properties has established a rapidly discharging, self-sustaining re-entrant loop of depolarizing current, which is discharging distally into the ventricles via the bundle of His, and also in a retrograde fashion into the atria. This is a micro re-entrant circuit occurring over a small area, and the small currents involved have no influence on the resting ECG. As the current is transmitted to the ventricles by the bundle of His, during such an attack we see a tachycardia with narrow QRS complexes. In addition, rapid retrograde depolarization of the atria is occurring, overriding SA node discharge. AV nodal reentrant tachycardia generates a heart rate greater than 130 beats per minute, and often much more rapid than this. In a junctional tachycardia arising secondary to a focus of increased automaticity, the rate tends to lie between 100 and 140 beats per minute. Note therefore that with tachyarrhythmias arising in the junctional region, the heart rate allows us to make an assumption about the mechanism generating the arrhythmia. A tachycardia originating in the junctional region with a rate greater than 140 beats per minute is certainly AV nodal reentrant tachycardia, while if the rate is less than 130 beats per minute, the tachyarrhythmia is labelled junctional. You will appreciate that there is a grey area. Rates between 130 and 140 beats per minute may or may not be due to a reentrant mechanism. As we'll see in the quiz section, whether we label such an arrhythmia as AV nodal reentrant tachycardia or junctional tachycardia is largely determined by the clinical context, and a definitive answer may require further investigation. The second doctor the young lady in the case study consulted spotted all the signs and made the correct diagnosis of AV nodal reentrant tachycardia. The clinical history of paroxysmal episodes is typical, and a normal resting ECG is expected. In addition, the doctor noted on both the 12-lead ECG obtained during the attack and on the patient's monitor the presence of small slurred S waves in lead 2. In fact, these are pseudo S waves and represent P wave activity as atrial depolarization is spreading upwards from the junctional region and is occurring after ventricular depolarization. The complete absence of S wave activity in lead 2 in the pre and post-attack ECGs supports the contention that these are indeed pseudo S waves. As we've seen, this pattern of atrial depolarization supports the contention that the abnormal depolarization focus is junctional in location. at a heart rate greater than 140 beats per minute. The nature of the depolarizing focus within the junctional region is reentrant. This tachyarrhythmia is AVNRT. It is also worth noting that the readout from the patient's monitor captured the moment of transition from sinus rhythm to tachycardia and is very telling. Freezing at this point, we can clearly identify the premature atrial ectopic which triggered the arrhythmia. We will now consider a common and very dangerous arrhythmia. The readout on this monitor is from a patient admitted to CCU following treatment for an acute myocardial infarction. The patient has just developed a potentially life-threatening arrhythmia. He has lost consciousness and is quickly cardioverted back into sinus rhythm by the CCU staff. Looking at a printout from the monitor at the time of the attack, you will appreciate that this tachyarrhythmia is quite different from those we have considered up to now. The QRS complexes are broad, at over 4 small squares in width, that is greater than 0.16 seconds in duration, well beyond our upper limit of normal. This is consistent with an origin of the arrhythmia from a focus situated below the bifurcation of the bundle of His. This is ventricular tachycardia, or VT. VT is extremely common, particularly in the setting of acute coronary syndrome, and is potentially lethal. In the presence of coronary arterial obstruction, infarction of myocardial tissue is not generally uniform. Particularly at the margins of vascular territories, there may be a degree of overlap in blood supply between vessels, and it is possible for strands of cells to survive within the infarcted area. Such a strand of viable tissue has lost much of its cellular contacts due to the death of surrounding tissue, and for this reason, depolarization and repolarization properties may differ significantly from unaffected tissue adjacent to the infarct. You learned in the preceding videos that these are the conditions in which reentrant loops arise, and the commonest mechanism triggering VT is re-entry triggered by premature ventricular contractions. In fact, looking back at our patient's monitor, this beat represents the initiating ventricular ectopic. You'll notice that the triggering ventricular ectopic is similar in morphology to the QRS complexes of the subsequent tachyarrhythmia. You will also appreciate that following an initial brief period of irregularity, the tachyarrhythmia is monotonously regular. This regularity is a very characteristic feature of ventricular tachycardia. In our patient's case, although not completely identical, the QRS complexes are very similar in morphology. This is a monomorphic ventricular tachycardia. The monomorphic morphology of the QRS complexes indicates that each episode of ventricular depolarization is originating from one single site within the chambers and is moving through the ventricular myocardium in a constant pattern. You may have spotted this earlier event on the patient's monitor. Ventricular tachycardia is present when more than 3 consecutive ventricular complexes occur at a rate of greater than 100 beats per minute. This run of 5 broad complex beats meets this definition of VT. Such a self-terminating run of VT, less than 30 seconds in duration, is referred to as a salvo of non-sustained VT. The term sustained ventricular tachycardia applies to an episode of VT greater than 30 seconds in duration, or, as in our case, an episode requiring clinical intervention for termination. We have already mentioned that it is possible for a focus situated in the supraventricular region to generate a broad complex tachycardia. This situation arises if a component of the ventricular conducting system is damaged or fails to function at higher heart rates. Distinguishing such a broad complex tachyarrhythmia from VT is a major challenge, which we will discuss in section 5. There are several features of VT which help us to make this distinction. Far from being detailed, a knowledge of these features will come in very useful. We will now deal with the most important of these features, atrioventricular dissociation. There is an interesting event on our patient's monitor at this point. In the middle of the tachyarrhythmia, we find an apparently normal QRS complex. This is a capture beat. The presence of a capture beat is evidence of atrioventricular dissociation. What does this mean, and why is it so important? Depolarization arising from a focus in the ventricle is not generally transmitted into the atria. Therefore, in VT, the atria may remain uninfluenced by events in the ventricles, and the SA node carries on discharging at its own inherent rate. Equally, the SA node discharges have no effect on the ventricles, as the great majority of P waves arriving at the AV node find the conducting system and ventricular muscle mass refractory to depolarization due to the rapid rate of discharge from the abnormal focus. Electrical events in the ventricles and atria are dissociated. The two regions are both doing their own thing, uninfluenced by one another. The presence of a capture beat in the rhythm strip is evidence of AV dissociation because, as illustrated here, it represents a rare P wave which has arrived at the junction at a point in time when the conducting system and ventricles are in a non-refractory state. The SA node discharge therefore depolarizes the ventricles through the normal pathway of the conducting system, generating a QRS complex of normal duration. Recognition of a normal QRS complex in a run of broad complex tachycardia, a capture beat, is strong evidence of AV dissociation. The presence of evidence of AV dissociation is very reassuring in diagnosing a broad complex tachycardia as VT. By definition, if electrical events in the two regions are occurring independent of one another, then ventricular depolarization is not being driven from a supraventricular focus. There are two other features we can look for to establish the presence of AV dissociation: the presence of fusion QRS complexes and dissociated P waves. We've already seen that a fusion QRS complex may arise if the SA node, uninfluenced by events in the ventricles, fires and depolarization is transmitted into the conducting system just as an ectopic ventricular focus discharges. The fusion QRS complex generated will demonstrate features of both sources of ventricular depolarization. To identify a fusion complex, we look for a QRS complex which differs in morphology from the surrounding complexes of the tachyarrhythmia, and which shares features of both the normal and broad QRS complexes. Like the complexes of the tachycardia, a fusion beat is bizarre in morphology, but bizarre in a different way. Although not obvious in our patient, With experience, it is possible in many cases to identify P-wave activity fused with the components of the broad complex tachycardia of VT. When identifiable, as in the example shown here, the P-waves bear no fixed relationship to the QRS complexes. This is strong evidence of AV dissociation. The atria and ventricles are depolarizing independently of one another. There are situations in which a supraventricular focus can generate a broad complex tachycardia with AV dissociation, but these situations are rare. In practice, evidence of AV dissociation in a broad complex tachycardia strongly favours a diagnosis of VT. Evidence of AV dissociation is detectable in approximately 50% of cases of ventricular tachycardia. There are many other features which help in the diagnosis of this arrhythmia, and we will discuss some of these in the quiz section and expand on this in section 5. Our patient experienced a run of sustained VT at approximately 150 beats per minute. The rate observed in VT is variable, but most commonly runs between 140 and 200 beats per minute. The high rates achieved in this arrhythmia and impaired ventricular filling are part of the reason why it is so dangerous. However, the highly abnormal pattern of ventricular depolarization is also a major contributor to cardiovascular instability in this arrhythmia. A highly deranged pattern of ventricular depolarization may result in an equally deranged pattern of ventricular myocardial contraction with loss of cardiac output. We've seen that spontaneous depolarization of sites outside the SA node can generate premature ectopic beats. Another phenomenon related to the inherent automaticity of cardiac tissue is the occurrence of escape beats and escape rhythms. In a diseased heart, the SA node may fail to depolarize the ventricles. This may occur either due to failure of the node to discharge or blockage of transmission of the depolarization wave from the node to the ventricles. In these scenarios, the next most rapidly discharging region of the heart, capable of depolarizing the ventricles, will take over as the cardiac pacemaker. In the example shown here, a prolonged period without an SA node discharge, this is termed a sinus pause, has ended with a discharge of depolarizing current from a region of the atrium. This is an atrial escape beat. Following the escape beat, the sinus node has recovered and is again driving the heart rate. The key factor in distinguishing an escape beat from a premature ectopic is its timing. Premature ectopics occur earlier than the next expected sinus beat, while escape beats occur later than the next expected sinus beat. If the SA node does not recover, the ectopic site may take over as cardiac pacemaker, generating an escape rhythm. However, as the automaticity of cardiac tissue declines on moving away from the SA node, the heart rate generated tends to be lower than sinus rhythm. Virtually any part of the heart can generate an escape rhythm. Precisely which site takes over from the SA node depends on the type of problem preventing the node from depolarizing the ventricles. We will go through the nature of these problems in section 5, but for now it is important to appreciate that as we move further distal to the SA node, the heart rate generated by an ectopic site becomes progressively slower. You will note from the heart rates quoted here that escape rhythms are therefore one potential cause of a bradycardia, that is, a heart rate less than 60 beats per minute. The site of origin of an escape rhythm gives it its name, and the site of origin for both escape beats and escape rhythms can be determined using exactly the same rules we've applied to the analysis of tachyarrhythmias. Escape rhythms arising above the bifurcation of the bundle of His will be narrow complex and may be atrial or junctional. An escape rhythm arising below the bifurcation of the bundle of His is broad complex and is termed a ventricular escape or idioventricular rhythm. We know that this bradycardic rhythm is not sinus bradycardia, as the P-wave axis is directed superiorly. With a PR interval in the normal range, it is likely to represent an atrial escape rhythm, an escape rhythm arising from a focus in the main mass of the atria, outside the SA node. We can identify this example as junctional, as it is narrow complex, completely regular, but with no identifiable P-waves. In this example, the P-waves are likely buried in the QRS complex. With broad QRS complexes and obvious AV dissociation, we can identify this bradycardia as idioventricular. It is important to realize that in the presence of enhanced automaticity of an ectopic site, it is possible for the rate of an escape rhythm to rise above 60 beats per minute. In this situation, when the heart rate generated from an ectopic atrial or junctional site lies between 60 and 99 beats per minute, the rhythm is described as accelerated. Keep in mind that the expected rate for a ventricular escape rhythm is in the region of 30 to 45 beats per minute. So an idioventricular rhythm is described as accelerated when the rate rises above 50 beats per minute. How do we tell such accelerated rhythms are not sinus? By applying exactly the same principles of analysis we used in analysing tachycardias: the duration of the QRS complex and the presence, timing and axis of P-waves. If you think about it, you will realize that the presence of an accelerated rhythm on a patient's ECG may or may not represent failure of the SA node to depolarize the ventricles. If, due to some disease process, a region of the heart develops enhanced automaticity and the rate of discharge from the abnormal ectopic site is more rapid than the inherent rate of discharge of the SA node, it is possible for the ectopic focus to override the node and take over pacemaker function. Provided the rate lies below 100 beats per minute, this is categorized as an accelerated rhythm. Of course, once the rate rises to 100 beats per minute or above, the rhythm is designated a tachycardia. Taking all of this information together, when dealing with the arrhythmias discussed in this section, we have a continuum of nomenclature based on the observed heart rate and the anatomical site of origin of the rhythm. This nomenclature is very straightforward. Under normal circumstances, the AV node forms the only route by which atrial depolarization can enter the ventricles. In some individuals, however, an accessory conducting pathway connects the atria and ventricles. Many different types of accessory pathways exist. One of the commonest varieties directly connects atrial and ventricular myocardium. Such a pathway is often composed of myocardial tissue and lacks the complex physiological properties of the AV node. In the presence of an accessory pathway, the SA node discharges, and depolarization is transmitted by the abnormal tissue into the ventricular myocardium without the physiological delay characteristic of transmission through the AV node. Depolarization transmitted by the pathway spreads slowly outside the conducting system through a localized region of ventricular myocardium. Such early depolarization of a small portion of ventricular myocardium is termed pre-excitation. As this process is taking place, and following the usual physiological delay, the AV node allows the atrial depolarization wave to pass into the bundle of His. The great bulk of the ventricles is then depolarized by signal spreading in the conventional way through the branches of the conducting system. This wave eventually meets the accessory pathway mediated signal, and the two waves cancel each other out. Of themselves, these events have no clinical consequences, but can produce a number of findings on the resting ECG. Pre-excitation results in an early onset of the QRS complex. This is at the expense of the PR interval, which is consequently shortened. As the accessory pathway mediated depolarization of a localized region of myocardium spreads slowly outside the conducting system, the deflection it produces on the ECG is slurred and is subsequently overwhelmed by the signal from conduction system mediated depolarization of the main mass of the ventricles. The slurred early deflection in the QRS complex produced by pre-excitation is termed a delta wave. The presence of a delta wave on the ECG not only results in shortening of the PR interval, but also in prolongation of the QRS complex. These ECG features, secondary to the presence of an accessory pathway, are referred to as the Wolff-Parkinson-White pattern. If the Wolff-Parkinson-White pattern is accompanied by paroxysmal attacks of tachycardia, the patient is said to suffer from the Wolff-Parkinson-White syndrome. Why should an individual with such an accessory tract be subject to paroxysms of tachycardia? Well, note how during a normal sinus discharge, the two currents transmitted into the ventricles physically fuse. This not only ends the contribution of the delta wave to ventricular depolarization, but also of course prevents the depolarization wave transmitted through the AV node from re-entering the atria. We've encountered a situation like this before. As you learned in section 4, the existence in the heart of two communicating pathways with differing electrical properties and whose depolarization waves ultimately limit the extent of each other's transmission is the substrate for a re-entrant loop. In this case, the re-entrant loop can be triggered by a premature ventricular or premature atrial contraction. The re-entrant tachycardia generated under these circumstances is termed AV re-entrant tachycardia. In the example shown here, the patient has just experienced a premature ventricular contraction at a time when the accessory tract is permissive to transmission of current. Depolarization generated from the ectopic site is transmitted into and depolarizes the atria. By the time the atrial depolarization wave reaches the AV node, it is ready to transmit the wave into the conducting system and depolarize the ventricles. Note, however, that in this sequence of events, there is now nothing preventing the wave from re-entering the accessory tract and depolarizing the atria from below. In this way, a rapidly discharging, self-sustaining re-entrant loop is established between the atria and ventricles, giving rise to AV re-entrant tachycardia. There are a few useful points to note at this stage. Firstly, once the re-entrant tachycardia is initiated, the ventricles are depolarized in their entirety by the conducting system. This includes the region of myocardium previously depolarized by the accessory pathway. So during a paroxysm of AV re-entrant tachycardia, the delta wave disappears and the QRS complexes of the tachycardia are narrow. Also, during the tachycardia, the atria are depolarized by current flowing upwards from the ventricles in a retrograde direction through the accessory pathway. Therefore, if we can identify the P waves during the attack, we would expect them to demonstrate an axis directed superiorly. That is, we would expect them to be negative in the inferior leads. One further point about the P waves which will come in very useful in practice is their distance from the preceding OR wave. At presentation, it may be difficult to distinguish AV re-entrant tachycardia from AV-NRT. AV re-entrant tachycardia generally results in faster heart rates, but as shown here, this is not always the case. There is another clue which you can use to try and distinguish these two narrow complex arrhythmias. You learned in section 4 that the P wave in AV-NRT may occur during or immediately following the preceding OR wave, producing a pseudo S wave in the inferior leads. In AV re-entrant tachycardia, because of the much larger distances travelled by the re-entrant current, a macro re-entrant circuit, if identifiable, the P wave tends to occur later in the cardiac cycle and is often observed as a distortion of the ST segment. In the example shown here, the experienced eye can identify this negative distortion of the ST segment as a P wave. The negative orientation of the P wave in lead 2 and its relatively long distance from the preceding OR wave is consistent with a diagnosis of AV re-entrant tachycardia. The distance between the preceding OR wave and the subsequent P wave on any ECG is termed the RP interval. We will discuss the RP interval again when we tackle tachyarrhythmia diagnosis in the quiz section. For now, note that both AV re-entrant tachycardia and AV-NRT are usually short RP interval tachycardias. What this means is that if we define the cardiac cycle by the interval between two OR waves, the onset of the P wave occurs in the first half of the cycle in both AV re-entrant tachycardia and AV-NRT. However, the RP interval tends to be longer in AV re-entrant tachycardia compared to AV-NRT, and this can help distinguish between the two. These are the characteristic ECG findings of orthodromic AV re-entrant tachycardia. The term orthodromic refers to the direction of flow of the re-entrant circuit entering the ventricles through the AV node. It is possible for an ectopic to establish a re-entrant circuit flowing into the ventricles through the accessory tract. This is an antidromic AV re-entrant tachycardia. In this situation, ventricular depolarization is transmitted outside the conducting system, resulting in an extremely dangerous broad complex tachyarrhythmia, which we will discuss in the quiz section.